Okay, assalamu alaikum everyone. I'm Menna Mousa, I'm a second year medical student. And today our topic is about the anatomy of splanchnic, vasculature, and the hepatobiliary system. That is a lot of words just to say that we're going to be talking about the liver. So if you guys need anything during the session or right after, please feel free to stop me at any time or contact me whenever needed. Okay, so now that we're done with the pro intro, let's get into the objectives. So starting with, whoa, the slide's not moving. Okay, so we're going to be talking about the liver anatomy and the structure. Then we're going to move on to the blood supply. We're going to talk about the portal veins, and then we're going to talk about some of the lymphatics, and we're going to end it with the gallbladder. Okay, but before we do all that, I want to make sure that you guys know the basics of everything, and I want to make sure that you know the embryological developments. Okay, so just like you guys know, we have the organs become either foregut, midgut, or hindgut organs. Okay. Um. So, like, what are the foregut organs? Let's say you have the esophagus, you have the pancreas, the stomach, the liver, and so on. And what about the midgut? The midgut are like, let's say, the duodenum, the ileum, the cecum, right? There's also the hindgut, which is like the sigmoid colon or the rectum. Okay. So, embryologically, they all differ. And why is that? Do you think that happened just because? Well, no, right? The differences are because it helps us explain, the nerve supply and the pain referral. So let's say a patient comes in with epigastric pain. So we know that okay, he's feeling, foregut, like a foregut organ is damaged, right? Or if he's feeling peri-umbilical pain, then it could be a midgut organ that's damaged. Okay. If you look also, we have the arterial supply. It's going to help us predict what organs are supplied by what artery, okay? So let's say that the celiac trunk is damaged. So what organs are going to be damaged? Well, we're probably going to be thinking of the foregut organs, right? What about the superior mesenteric? Then we're going to think of the midgut organs, okay? And last but not least, it tells us about the cancer metastasis and the lymphatics in general and so on, right? So let's say a patient comes in with colon cancer in the ascending colon, okay? So which lymph node are the surgeons going to move? Is it the celiac? Is it the superior mesenteric, right? So this division is going to help us identify that, okay? If you guys looked at this slide and you feel like you understand nothing, well, that's okay, because we're going to be breaking down every single thing that I've mentioned here, okay? And starting with, we're going to be talking about the nerve supply, or the specifics of the divisions of the abdominal organs, okay? So as you guys know, they're divided into four quadrants: the right upper, the right lower, the left upper quadrant, and the left lower quadrants. But they felt like that wasn't enough. So they decided to do, instead of four, we moved on to this XO looking thingy, okay? So what do we start with? Here, over here, we have the epigastric. Epi means like up above or like on, and gastric is, the stomach, right? So epigastric means that I'm talking about a place that is above the stomach, okay? Then over here, I have the umbilical cord, right? So this region is called the umbilical region, okay? Then over here, I have the pubic symphysis. So what is this place going to be called? The suprapubic. Why supra? Because it's above. Okay? Okay. Then they looked over here and they noticed that these regions are below the coastal cartilages. Okay? So what did they call them? They called them the hypochondrium. You have the right and you have the left. Okay? Then you have these regions, which are known as the right lumbar and the left lumbar. Why are they lumbar? It's not just because you have the lumbar vertebrae there. It's because the word lumbar comes from lumbus in Latin, okay? And what does lumbus mean? It means like the loin, or like, the side of the lower back and so on. So when I'm talking about the lumbar region, I'm not just talking about the lumbar vertebrae. I'm also talking about the posterior wall and, the muscles of the lower back, okay? And to end this all, we have the inguinal regions. Easy so far? All right. Now for our main character, which is the liver. Okay. As you guys can see, it starts at the right hypochondrium and it extends all the way through the epigastric to become a little bit above the left hypochondrium. Okay. So let's zoom in onto it. Here it is. in relative to the costal cartilages, you have that it starts at the 7th rib and it ends at the 11th rib. Okay, and the highest point, because like you can see, this part is higher than the rest of them. Okay, so the highest point is at the 5th rib. All right. Okay. So let's say I want to see it through an ultrasound. How am I going to see it? I'm going to go to the mid-axillary line and I'm going to look. I'm going to put, the ultrasound device over here somewhere, okay? And that's how I'm going to get access to the liver, all right? Easy stuff, easy stuff. Now, one more thing that I wanted to mention is, the whole idea about the 5th rib. Why is that important? Personally, last year when I saw that, صراحة, like I skipped it. But this year, I discovered that at the 5th rib, or the nipple region, if a patient comes in with a stab, I'm not just thinking now of just suturing the skin. I'm also thinking of a possible liver injury. Okay? Yeah, the liver injury. All right. So again, this is everything that I mentioned. So the liver is the largest internal organ. If I'm talking about its width, I say that it starts at the right hypochondrium, and then it goes across the epigastric into the left hypochondrium. The height-wise, it starts at the 7th rib all the way to the 11th. Okay, but the highest part over here starts at the 5th rib. And why is that important? Because of liver injury. Okay. Okay, now let's talk about its lobes and its divisions. Okay, we have anatomical division and we have functional divisions. Let's start with the anatomical. The anatomical can be divided furthermore into diaphragmatic and visceral. Okay, hold on. What does any of that mean? When I'm talking about the diaphragmatic, it's surely the surface that's in contact with the diaphragm. Okay, and what about the visceral? It's the surfaces that are not in contact with the diaphragm and are rather in contact with other abdominal organs. Okay, well, why is this division important? Again, why am I making this harder on myself? Because look at these patients. Let's say a patient comes in with shoulder pain. Okay, when I think of shoulder pain, I'm thinking of pain at the dermatome C3 to C5. Okay, like what supplies C3 to C5? Do you guys know? Back to CVP. No? Okay. Well, C3 to C5 is supplied by the phrenic nerve. Okay. And again, based on CVP knowledge, the phrenic nerve is what keeps the diaphragm alive. Okay. So the fact that there's shoulder pain could tell me that there is a diaphragmatic surface that is damaged. Okay. All right. Well, what about the visceral? In the visceral, a patient would come in with, let's say, a right upper quadrant pain. So that tells me that, okay, we're talking about abdominal organs. So I'll check, the visceral surfaces. Okay? Slides are not moving. Okay. Now let's focus onto the diaphragmatic part. So this is how it looks like. What exactly do you guys have to know? You have to know the names of the different ones. So we have the anterior diaphragmatic, the superior diaphragmatic, the posterior, and the right. Now, again, based on last year's knowledge, honestly, that made no sense to me. Like, what the names just like what? So let me tell you. Let me break it down for you. The anterior diaphragmatic means that it's the front part. Okay, so it's the part that's facing the abdominal wall. Then, when we talk about the posterior diaphragmatic, it's posterior, right? So it's facing the vertebral column. Okay. Then we talk about the superior diaphragmatic. What is it superior to? It's superior to this like little lobe of the liver. Okay. And then the most exciting one is the right diaphragmatic. How is it right? Because it extends along the right costal cartilages or the right ribs. Okay. This honestly was, I was pretty shocked to be honest when I figured that out. Okay. Did you guys notice anything weird here? Anything that, caught your eye? No? Nothing at all? Oh, wait, let me zoom in a bit more. What about that? So, no? Okay. One more? Okay. Well, we'll talk about this little guy over here. Okay. So, what is this guy? This guy is known as the falciparum ligament. What is it? It's basically the ligament that divides the liver into a left lobe and a right lobe. Okay? Okay. And what is it? What is it basically like? What is it made up of? It is the remnant of the umbilical vein. You have the arteries travels to the umbilical. To be honest, I have no idea what the relation between that is. But honestly, like, I don't know, I just feel like it makes sense, arteries travels to umbilical. Like it's catchy, You'll memorize, you'll find yourself knowing it. Anyways, you have over here, it looks like a little curtain, okay? And at the end of the curtain, there's like a little rope to it. This rope has what we call by the ligamentum teres, which is the remnant of the umbilical vein, okay? Now, around this ligamentum teres, you have para-umbilical veins. And what are these? You guys didn't delve too much into them, so we're not going to talk about too much. We're not going to talk about their functions, but they're basically needed for anastomosis. Okay? Okay. Now let's zoom back out and let's look at the posterior view. I feel like this guy is, a bit more obvious here. Well, if you thought of the bare area, then you're right. Let's talk about it. Oh, okay. So, as we know, the liver is an intraperitoneal organ, which means that it's covered by peritoneum except for the certain regions. Like over here, we can see the bare area. Now, this bare area allows the attachment of the liver to the diaphragm, okay? And the fact that it lacks a peritoneal barrier means that the spread of infections is not localized to the liver anymore. Now, the spread of infections are going to go directly to the diaphragm. Okay, so the liver is known to get infected, right? So if the liver gets infected, it's going right away to the diaphragm, it's going right away to the mediastinum, and you're going to tell by the right shoulder pain that we talked about. Do you guys remember that? Because of, the diaphragmatic irritation. Okay, and this is, again, everything that I've mentioned, just in words form, if you guys want to go through that. Now, let's move on from the diaphragmatic to the visceral, okay, which are the surfaces that are in contact with the abdominal organs themselves. If you look at it, honestly, it's a bit overstimulating. So on this side, you have esophagus, stomach, biliary part of the stomach, right colic flexure. So just instead of, passively reading through them, I'm just going to tell you how to make sense of them, okay? So this is the left or right side. Which side is that? I mean, over here we have the word right, so it makes sense that this is the left. Okay, so on the left side, you can see the depression of the esophagus and the stomach, okay? And that makes sense because the esophagus and the stomach are both found in the left upper quadrant, okay? Okay, then as you're going towards the middle, you're going to see that it's moving from it's like the digestion transition out of the stomach, okay? So this is where you start finding the duodenum, the biliary part of the stomach, which is, the last part of the stomach, and so on, okay? So over here, you can see they're dense, right? Then you come to this side, and you can see organs like suprarenal and right kidney and the right flexure. All these are the organs that are retroperitoneal, okay? So they're found in the back, okay? Easy so far? Okay. Now, before moving on, I want to show you guys this thing over here. You can see that there's a clear H letter over here, right? A lot of structures over here. So this H is based on the portal hepatis. This guy over here. What is the portal hepatis or the porta hepatis? It's just, like an opening that has van or vad actually over here in this case. You guys remember van, which is the vein, the artery, and the nerve? This guy is vad, the vein, the artery, and the duct. Okay? This is the reference point over here for the H. If you look over here, we have ligaments. Over here, we have the falciparum, like we talked about. And on this side, we have the gallbladder and the inferior IVC, okay? What is this extra lobes that are found? What are these? You guys know them? Okay. So for the superior part, we call it the caudate lobe. Yes, exactly. Exactly. And for the inferior part, we call it the quadrate lobe. Now, how I used to remember it is like the caudate, like in the army, how they have more respect, so they're found more superior. Okay. And then you have the quadrate lobe. Okay. And this is, and this is the porta hepatis, which we talked about. So this is a picture that I found that honestly I feel like is pretty helpful. So on one side, we have the fossas, and on the other side, we have the ligament. And just keep in mind that this picture is opposite to what the previous picture was, just so that you don't get confused. We have the quadrate is right next to the gallbladder, and we have the caudate next to the IVC. So you can take it as C in IVC for the caudate, and yeah, okay. There's no cues over here. Okay, makes sense. The relations are important for structure wise. So they might just get you a question that let's say, well, what kind of questions do they get? Let's say like the gallbladder fossa. Let's say the gallbladder has like an issue, okay, like a stone or something. So what's the structure in the liver that could get affected? What's the closest to that? It's probably the quadrate lobe. Makes sense? Also, these are important because they come in auspices and so on. Okay? Okay. It's very possible that we have visceral surfaces with no peritoneal coverings. That sentence confused me for some reason, but yes, you can have visceral surfaces with no peritoneal coverings. Like what? Like these. Okay? Bombardment of words. So let's break it down. First thing, just like we already talked about, the bare area. Again, the bare area is the area that is not covered by a peritoneum. And it makes sense that it's not covered by a peritoneum. Why? Because we said that it's the attachment point between the liver and the diaphragm. So if it has peritoneum, then it's going to be, slippery and it's not going to be that stable. Okay? So, the anatomy is helping its function. Okay? That's for the first part. For the second part, we have the porta hepatis, again, which we talked about over here. So they contain the VAD or the portal triad. Now imagine this is like a little portal or like a door to the liver. Okay, it allows the entry and the exit of the portal triad. Imagine a door having peritoneum. Would the vein and the arteries and the ducts, would they sit comfortably in there? Probably not, right? Okay. Which vein is it? Do you guys know? Which vein and artery sit in there? And which duct? So we have, where's the chart? Okay. So we have the portal vein, the hepatic artery, and the bile duct. Okay? And this is the little portal for you guys to remember it. Okay. Then we talk about the fissures. We already know this guy, right? Which we said is the remnant of the umbilical vein. We have the other guy, which is the venosum. And this is the ductus venosus remnant. Now this is, a bit more embryo, but you have to know it, okay? It sits posterior to the porta hepatis, all right? And then for our last guy, it's the gallbladder fossa, which again we already talked about. So it's a depression where the gallbladder sits, okay? Like, why don't we have peritoneum on top of that region? Diaphragm attachment. Okay, the diaphragm is more attached to the bare area, but yes, it's also attachment. So the gallbladder is attached to the liver, right? So if again we have peritoneum, it's not going to be well attached. And another thing is that the local infection spread. Again, if the liver is infected, if yeah, no worries. If we have an infection, in this case, it's gonna go directly where? To the diaphragm, right? Okay, now for our first. Okay, so a fossa is just an opening. Okay, it's just a space. Yes, exactly. Okay, so for our first checkpoint, are you guys okay so far? Okay, let's solve this question. Let's see if you guys can clock it. Least likely. Yes, exactly. Can you guys explain why? The rest are in the porta hepatis. Exactly. That's exactly the answer. So the porta hepatis contains the portal vein, the hepatic artery, and the common bile duct. So VAD. Okay? Because it contains the common bile duct. It's remember the VAD, vein, artery, and duct. We'll get to that at the very end when we talk about the gallbladder. Okay? So yes, you're right. It's the cystic artery. Now we talked about the anatomical divisions, so let's move into the functional divisions. Okay, so as you guys know, the liver has a lot of functions. Okay, so a lot of function means that it needs a lot of blood supply. So imagine like it's only supplied by a single vessel, and a blockage happens there. Then what happens? The liver is gonna die right away, right? I can't prevent the death of the liver if it's only supplied by one vessel, right? Can you guys name any of the liver, the functions of the liver? We got a couple over here. Bile. Okay, yes, that's right. Detoxifying. Okay, that's a good one. Yes. One more, and I'll let you guys go. Okay, alcohol metabolism. That's kind of part of the detoxifying. Okay, so we have detoxifying, producing the bile, and processing nutrients. I want you guys to focus on this one, and filtering the blood. Okay, and since we're talking about blood, let's move into the next part, which is the arterial supply. You'll make sense of these at the very end, inshallah. Okay, so this is how everything looks over here. You have the ascending aorta coming out of the heart, right? You have the aortic arc, and then you have the descending aorta, which becomes an abdominal aorta at the level of T12. Okay? Now, the abdominal aorta gives me different branches, main branches, which is the celiac trunk, the superior mesenteric artery, the inferior mesenteric artery, and all of these supply anterior structures. And then you have the median sacral, which supplies posterior. Okay. Let's load this down. Okay. This is how they look like, by the way. Just, waving into each other. But we'll make sense of them after this, inshallah. Okay? So let's start with the celiac trunk over here. Now, the celiac trunk is one of the main arteries in there. Okay? It starts at the level of T12, which is, fun fact, the same level as the aortic hiatus. Okay? And then it's going to give me three main branches. Anytime I say big boss, by the way, it means that it gives a lot of branches. Okay, and you'll notice they keep coming. All right. So what are the three branches? You have the left gastric, you have the splenic artery, and you have the common hepatic artery. Personally, I struggle with memorizing, so I use a lot of mnemonics. And how I remembered that is this mnemonic, the left hand side. So L for the left gastric, H for the hepatic artery, and S for the splenic artery. Okay. Okay. Let's talk more about the left gastric artery. So this is how it looks like. This is the celiac trunk over here at the level of T12, and it's going to give this small branch over here. Now, this is a small branch, but it has a very big impact, right? So it supplies the upper part of the lesser curvature of the stomach. So as you guys know, this is known as the lesser curvature, and this is the greater curvature. So it supplies the upper part of the lesser curvature of the stomach. And since it's already up, it also gives branches to the esophagus, so the lower part of the esophagus. Okay? And it runs between the layers of the lesser omentum. All right? So everything is just less. Okay? طيب, this is the left gastric artery. What happened to the right? Where did the right go? Okay. We'll talk about that later, but I want you to keep it in mind. Okay? For now, let's move on to the splenic artery. The splenic artery, this is how it looks like, by the way. It's a very long artery right there. And it gives a lot of branches. Again, a very big boss, okay? So it runs along a lot of organs, and whatever organ it passes by, it just gives it. It's very, considerate like that. It gives a lot of branches to a lot of organs. So as you can see here, it passes by the pancreas all the way until it reaches the spleen. So it's going to give the pancreas some branches, and then it's going to go into the hilum of the spleen to, again, give the splenic arteries. And then it's going to supply the stomach, the fundus of the stomach in specific, which is known as the short gastric arteries. And as it terminates, as it's about to end, it's going to give what we know by the left gastroepiploic. Do you guys know the story of the gastroepiploic? The word epiploic comes from, again, another Latin word, which is known as epiploin, okay? And epiploin just means like it's something that's floating, okay? So when the anatomists saw that, the omentum, they looked at it and they were like, okay, that's not a mesentery, and that's not a ligament, that's not a vein, what is that? So it was just something floating on the visceral surfaces. So they decided to call it epiploin, okay? So from the name, you can tell what it supplies, gastroepiploic. So it's going to give, yes, it can be called the left, yes, the gastroomental artery. You're right. So from the name, gastroepiploic, gastro supplying the stomach, the greater curvature of the stomach to be specific, over here. Okay, it's going to give the greater curvature, and it's going to supply the omentum, like we mentioned. Okay, because of the epiploic part. Easy? Okay. Now let's move on to, oh, yeah, before we move on, By the way, this is a picture that just the words are just simplified from your lecture. But like the minute I saw that, I was like, oh my god, like please, like, and then I realized the word please stands for, you know, these letters. So P for pancreas, L for the left gastroepiploic, S for spleen, and the other S for short gastrics. Okay? So as you guys go through medicine, please just make, you know, random mnemonics that you feel like would help. Okay? Now, for our last trunk or artery, a branch coming from the celiac trunk, we have the common hepatic artery. And whenever I think of the common hepatic, I think of like, you know, the main highways and like, you know, Mecca Road and Khurais and so on, right? It acts exactly like that way, okay? So it's going to give a branch that goes up and it's going to give a branch that goes down, okay? These are the names of the branches. You can think of it as like a highway that goes on a hill, okay? So when you're going on a hill, you're losing your energy and you're kind of like taking the L, okay? So the first branch taking the L supplies the liver, the lesser curvature, and the lesser momentum. What is this called? It's called the hepatic artery proper. Okay, this is the name of the artery that goes up. Now for the artery that goes down, it supplies what's down there. You have, you know, the duodenum, you have the stomach as well. So we call it the gastroduodenal artery. Okay, so it goes down to supply the gastroduodenum, the duodenum, the pancreas, and the greater omentum. Okay, why is this significant to know? Because let's say there's an ulcer at the first part of the duodenum. Okay, which artery is going to be affected? I remember I think that got asked either like during a session or in the exam, but it was a high yield. So which artery would be affected? You directly understand that it's the gastroduodenal artery. Make sense? Yes, the short gastric supplies the fundus. Okay. So let's delve more into it. Each alone. We have the hepatic artery proper. What does this guy do? Again, hepatic artery is the one that goes up. And remember our question that we had in mind? You know, the right gastric artery. Also, there's another question here that we should have had in mind, but we moved on from it. Where is it? Yeah, hold on. Here, we said the left gastroepiploic. Where's the right? Why are they leaving the right out? So this artery over here, the hepatic artery proper, is going to answer the first question. The hepatic artery proper is the one that gives the right gastric artery, okay? So the left gastric artery comes from the celiac trunk right away, okay? The right gastric artery comes from the hepatic artery proper to supply the lower part of the lesser curvature of the stomach. Again, this is the left curvature. What's supplying the lesser part? It's the right gastric. What supplies the upper part? It's the left gastric. Easy? Now, another thing that I want you to keep in mind for, you know, the very end is the small artery that the right gastric gives, which is the cystic artery. The cystic artery supplies the gallbladder. Okay? Then we have the second one, which is the right and the left hepatic arteries, which supply the liver. Easy? I mean, left hepatic, you know, so it just makes sense that it's the liver. Okay? You can also see over here that they join together to make, you know, an arcade. Which ones? The left gastric and the right gastric. Okay. Now I move on to the next guy, which is the gastroduodenal artery. Now, G stands for genie. And as I was looking at this, I felt like, you know, just makes sense right here. I mean, it doesn't exactly fit, but, you know, it works. So this guy is going to give us our last wish, you know. He's going to answer our last wish, which is, where did the right gastroepiploic come from? It's right here. So the right gastroepiploic artery comes from the right side of the greater, the right gastroepiploic artery comes from the gastroduodenal artery. And what does it supply? It supplies the right side of the greater curvature along with the omentum. So when we talked about the left gastroduodenal, where did it come from? The left gastroepiploic. Exactly, the sphenic artery. Okay, left gastroepiploic came from the sphenic artery to supply the left side of the greater curvature of the stomach. The greater curvature. Okay, so we're not talking about this guy anymore. We're talking about this guy over here. All right, and the omentum. Here it does the same, but it supplies the right side of the greater curvature. Okay, so it makes sense. Right supplying the right, and left supplying the left. Then this guy over here, which is a very important one, and you'll see later on why. But just keep in mind that the big word is branched from the big word. Okay, so gastroduodenal gives pancreaticoduodenal. It gives anterior and posterior superior. Okay, not the inferior. Keep that in mind. Superior, anterior, and posterior pancreaticoduodenal artery. Okay? Well, actually, let me write that down just so that it does not confuse you. Okay. Okay. All right. Well, why is the size moving? Okay. So we mentioned a lot of curvatures and, a lot of stomach here and stomach there. So just to, define them all in one slide, this is the last resort for the stomach. This is kind of like a tip and trick kind of thing. So the lesser curvature is supplied by the lesser word, gastric, just a small word over here. While the greater curvatures are supplied by the gastroepiploidic, the greater words or the bigger words. Okay? So whenever I say gastric, we're directly thinking of lesser curvature. Whenever I say gastroepiploidic, we're thinking of the greater curvature. Okay? So back to the lesser curvature, again, supplied by the right gastric artery. Hold on, let me move from here so that you guys don't see it. Where did the left gastric artery come from? Left gastric. Quick answers, quick answers. C trunk. Okay, yes, the celiac trunk. Okay, and where did the right come from? Not the gastroduodenal, no. Try one more. The gastroduodenal gave the big words, right? It's over here. It gives the big words, gastroepiploidic and pancreaticoduodenal. The gastric, which is the small word, is supplied from the proper hepatic. Exactly. Okay, the proper hepatic and specific, not the common hepatic, the proper. All right, the proper hepatic is a branch of the common hepatic. Okay, and it runs along the lesser omentum. So everything over here is just lesser. Okay, then we move on to the greater curvature, and it runs along the greater omentum, and again, it's supplied by the big words. Okay, so you have the left gastroepiploidic coming from the splenic, and you have the right gastroepiploidic coming from the gastroduodenal. This is the genie that answered our wish. Okay. Okay, well, you made it through another section, so congrats, guys. This is a little checkpoint. If you guys want to breathe, if you guys want to, get some water. Do you think you can answer that as you get some water? Nice. Okay, that was quick. Right. Okay. So we're saying, I'm not even, like, you don't need to read everything, they're just saying that which of the following arteries was ligated. Okay. So here we take a quick look. We see that they're talking about the lesser curvature and they're talking about the upper stomach. Okay. So lesser curvature, we're talking about the gastrics. Okay. So you can easily remove A, B, and E. Okay. So we're focused on C and D now. They're saying near the upper stomach. Which artery supplies the upper stomach? It's the left gastric. Like, what does the right gastric supply? The lower part of the stomach, the lower part of the lesser curvature of the stomach. Okay, so you were right. It is the left gastric artery. All good so far? Okay, so let's move on to our next branch, which is SMA, or the superior mesenteric artery. Okay, okay. What about it? What do we have to know? A couple of things, okay? The first is that it comes out of the level of L1, okay? So it comes out from the anterior aorta at the level of L1. The celiac came from which level? T12, exactly. So over here, L1. And as you guys can see, we removed the pancreas. The issue with this artery is that the minute it comes out, it's faced by the pancreas. So it has two solutions. Either that it's going to go through the pancreas or it's going to go below the pancreas. And surely, going below is the easier choice. Okay? So that's exactly what it's going to do. It's going to go down to supply the mid-gut organs. So we're done with the celiac, which supplies the foregut. Now we're here at the superior mesenteric, which supplies the midgut. Okay? So it goes down inferiorly. And as it's going down, it's going to be met by something that we call by the root of the mesentery. Okay, so you know how the organs are attached to the posterior abdominal wall to, through the mesentery or through the peritoneum and so on? The small region of attachment is what we call by the roots of mesentery. So the superior mesenteric artery is gonna go through that to give me the duodenal and the ileal branches. That's how it gets access to the duodenal and the ileal and the ileum. Okay. Okay. So far we know that it supplies these small intestines by giving me what? By giving me duodenal branches and ileal branches. And what else is it gonna give? It's gonna give the inferior pancreaticoduodenal artery. This is the part that I told you guys to keep in mind. So if I'm talking about the superior, superior either anterior or posterior, then I say that it comes from. If I say the superior, then where does it come from? The gastroduodenal, exactly. So only the small intestine branches pass through the peritoneum. What do you mean by that? It's the whole artery that goes in there. Just so that it gets access to the duodenum, it has to go through the peritoneum, or the root of mesentery to be specific. Okay. Okay. Now, when we talk about the inferior, now you have to keep in mind that we're not in the celiac anymore. We are in the superior mesenteric artery. Okay? So again, three branches so far that we've talked about, or three main branches. We talk about the duodenal artery, the ileal artery, and the inferior pancreaticoduodenal artery. All of these supplying the small intestines. Okay? Then it's going to keep going, as you guys can see, and it's going to terminate over here in what we call by the ileocolic neighborhood. Okay, so as you guys can see, it gives colic, and ileocolic. This is where it terminates. Okay, so each of these branches gives two or more other branches. All right, so here we talk about the middle colic, which gives a right and a left branch. Okay, now this needs visualization, so I need you guys to focus here. Okay, so the middle colic is going to give a right branch, which is going to anastomose with the superior part of the right colic artery. Easy so far? So there's anastomosis between the middle colic, the right middle colic artery, and the superior right colic artery. Okay? Now the right colic artery is going to give another branch, which is going downwards. Okay? What is this branch going to anastomose with? It's going to anastomose with the superior branch of the ileocolic artery. Okay? Okay. Easy so far? Are you guys getting it? So it's just a matter of anastomosing. So in case, let's say, I don't have the ileocolic anymore, what's going to happen? Okay, so what's going to happen is that the right colic is going to take over and it's going to be supplying the organs that the ileocolic was originally supplying. Okay, now this is for the superior part of the ileocolic. For the inferior part of the ileocolic, I use the mnemonic ASIC, okay, because the ileocolic over here, you'll have like the appendix, okay, so it's like you're saying a sick appendix, okay. ASIC, it's spelled as ACIC. All right. So A is for appendicular, C is for cecal, okay, anterior and posterior cecal arteries. The other C is for colic, and then we have an I for the terminal ileum. I have them all written down, but I want you guys to just focus on how they look for now. Okay. So again, middle giving right and left. The right anastomoses with the superior part of the right colic, and then you have the posterior part, or sorry, the inferior part, which anastomoses with the superior ileocolic artery, and then the inferior branch of the ileocolic is going to give me appendicular branch, cecal branch, ileal branch, and ascending colon branch. Okay? So far we've supplied the small intestines and we've supplied the ileocolic neighborhood. Okay? Here you can take a clearer look. Again, it starts at L1, leaves the pancreas inferiorly, okay? And is going to give me the duodenal branches, which, as you guys can see, each branch gives more than one branch. It's going to also give me the ileal branches. Middle and right comes from SMA, because then we have, the left that comes from the IMA. So you have to keep in mind that middle and right come from the SMA. And you have this guy over here, which is very, very important to differentiate that the inferior comes from the SMA, and the superior comes from the celiac trunk. Okay? This is the terminal part of it, the ileocolic neighborhood. So you guys can see, you can have a clearer look at the anastomosis. Okay? And this is the last part of it. So I want you guys to keep in mind the references. So as we said, the SMA goes posterior and inferior to the pancreas. Okay? So this is how it's going to look like. I'm going to have the pancreas, and right behind it, I'm going to have the SMA, and then I'm going to have a renal vein and the aorta, the last thing. Okay? So this goes from anterior to why is this so far? Okay, this goes from anterior to posterior. Most posterior, most anterior. Okay? So let's say you have pancreatic enlargement. Can you have a pancreatic enlargement? Okay, anyways, let's say you do have a pancreatic enlargement. Which artery is going to be damaged? The SMA. Okay, it's going to be crushed in the back. All right? Let's say you have the opposite, renal enlargement. So what's going to happen? Again, the SMA is going to be affected. Okay? So you just have to keep in mind the relations. And everything I said is over here again in word form if you guys would like to go through that. So keep in mind, SMA supplies the midgut. Okay? All right? Okay. Now another checkpoint. You guys want to do this one? It's a bit longer here. C. Okay, why do you say that is? Okay. Do you guys all agree with the answer? I personally think I agree. That's a pretty good answer. Yes, exactly. Thank you so much. So for the inferior pancreaticoduodenal, again, it comes from the superior mesenteric, while the superior part of the pancreaticoduodenal artery comes from, where does it come from? The gastroduodenal. Okay, exactly. So the big word goes with the big word. All right. So good job. Thank you so much. Okay, and now for our last part of the artery, and it's the IMA. Now the IMA is cuter, to be honest. So alhamdulillah, you don't need to dread this part. So let's get right into it. Okay, so the IMA comes from which level? It comes from L3. So we said celiac comes from T12, superior mesenteric comes from L1, and inferior mesenteric comes from L3. Okay, now the inferior mesenteric, as you guys can see, it supplies the hind gut. All right, so what does it supply? It supplies 1/3 of the transverse colon all the way to the anal canal. Okay, and it gives me 3 main branches. There goes one, there goes two. This is one main one with a lot of mini ones, and the third one. Okay, the first one is the left colic. So we said the middle and the right from the SMA, and the left colic from the IMA. Okay, imagine like the left. You know how you write the small L, in lowercase. This is exactly the same. Okay, so left comes from IMA. Okay. Okay, and as you can see, again, it's doing the whole 2 branches thing. It's giving an anterior branch, and it's giving, sorry, not anterior, it's giving superior, and it's giving inferior. Okay, so this ascending branch is going to anastomose with the middle colic that comes from SMA. Okay, so there's a continuation here where you have the middle colic. That's where the anastomosis is going to be. Okay, then you have the descending branch. As you can see, it's going to anastomose. Wow, it's going to anastomose with the sigmoidal arteries. Okay, okay. Okay, then let's talk about the sigmoidal arteries. What about them? As you can see, they have like 3 or 4 branches, okay, supplying the sigmoid colon, and their branches anastomose with the left colic. So left colic anastomoses with the middle colic and with the sigmoid. And the sigmoid anastomoses with the left colic. Easy? And now for our last branch, which is the superior rectal artery. This is the superior rectal artery over here. As you can see, it's a direct branch of the IMA. It doesn't go left, it doesn't go right, it's right away. Okay, what is it going to supply? It's going to supply the rectum and the upper anal canal. Okay? Rectum and the upper anal. The upper half of the anal, not the lower, just the upper. Okay? So again, quick review. We have 3 branches: left colic, sigmoidal, and the superior rectal. Left colic anastomoses with the middle colic, and with the sigmoidal. The sigmoidal is a very big one over here. It's going to give more than one branch, and as you can see, it anastomoses with the left colic, while the others supply the sigmoid colon. Okay? Then for the last branch, which is the superior rectal artery, notice we said superior, it's gonna go right away down to supply the rectum and the upper half of the anal canal. Now I can't say the upper half without saying I can't talk about the rectum without talking about the other arteries. So, oh yeah, this is the written format of everything I've been saying. This guy, this scary guy. So as you can see, we have more arteries. You have the median sacral, which comes from the aorta posteriorly. So everything we've talked about comes anteriorly, except for the median sacral, it comes from the aorta posteriorly. Okay? Then we have a superior rectal, a medial rectal, and an inferior rectal. Okay? The importance is not to remember superior, inferior. It's important to just remember where they come from. So as we already mentioned, superior comes from the IMA right away, right? It's a direct branch. The middle rectal comes from the interior iliac. So you can think of it as mid-L and then, iliac kind of thing, okay? And then M is for muscles. So whenever they say medial rectal, you're directly thinking of the muscles of, the organs, okay? We're not thinking of, peritoneal supply, all right? Then the last one is the inferior rectal. And honestly, I have no mnemonics for this one, but you have that it comes from the interior pudendal. P for pudendal stands for P for pelvic floor. And if you ask me, I'd say that the inferior rectal is the most important because it continues on with you to, ERP and so on. Okay? Okay. Now let's take a minute to breathe. This is a little ad break over here. You guys, if you want to go get water, if you want to, I know it's probably a long day. Are you guys good? Yeah, so it's these arteries are the rest of the rectum. Okay? The rectum and the anal and so on. Okay? Now, let me talk about the marginal artery of Dermond as we take a minute. This is the cute part, but you just have to know the name, honestly. Like, it's a very easy concept. I don't know why they gave it more than one slide. But basically, you need to use strength, okay? So, like we mentioned, we have the left colic anastomosis with the middle colic. And these over here are the little marginal arteries. So, you need this anastomosis, you need them to be together, okay? Because the more arteries there is, the more likely you'd save an organ. You'd save an organ from, failure, okay? So, just like we mentioned with the liver, we need more than one supply. And speaking of the liver, I feel like we lost the plot here. We were talking about the function. What happened? Why did we dive that deep in? Okay, well, now that we're back, can you guys tell me which arteries supply the liver? Okay, hepatic. So you're right, hepatic supplies 30% of the liver. Congrats, you got 30% of the supply. Where's the rest of the 70? Do you guys know this one? Portal vein. Yes, mashallah, exactly. Perfect. Portal vein. So this portal vein is important for the functional division of the liver. How? You guys don't really know, you don't need to know this in details, but let me just explain it so that it would make sense to you, okay? All you need to know is that it's divided into 8 segments. How does that happen? Anatomically, when we're talking about the anatomy, we say that the liver is divided into left and right by the falciparum, right? When I'm talking about it functionally, I say that it is divided into a left and a right through the portal. Okay? So the portal vein I'm gonna have two portal veins, right? A right portal vein and a left portal vein. The right portal vein supplying the right side and the left portal vein supplying the left side. Okay? Okay. And then there's the hepatic, which is, between them in there. All right? Okay. Now let me tell you how we got these 8 segments. First, we start with the right side. The right side is divided into an anterior and into, kind of like imagine it 3D, okay? So you have an anterior side and you have a posterior side. And each of these anterior and posterior, they're divided into a superior and inferior, okay? So imagine anterior divided into 2, superior, inferior, and posterior divided into another 2, superior, inferior. So how many do we have so far? We have 4, okay? Then you come over here and you look at it, and again, you have it in a 3D shape. So you have this anterior side and from the back, and you have this anterior side and from the back. So how many do we have? Again, 4. Okay, so how many do they give us? 8 in total. You don't really need to know the names, you don't need to know any of it. Just understand and know that it's 8 segments. What divides them? The portal vein. Okay? And between them, there's the hepatic veins. Okay. Now let's talk more about the portal vein. What is the portal vein? What is the function of the portal vein? Let's talk about it. So basically, one of the functions of the liver that we talked about is the processing of the nutrients. Okay. So when the blood goes, this kind of vein doesn't take the blood to the heart; it takes it to the liver for the processing of the nutrients. Okay? So what is a portal vein? It's a vein that does not drain to the heart, it drains to the liver. Now, where does the blood come from? It comes from the GI. It comes from, just like we mentioned, it comes from the gallbladder, the spleen, the pancreas, and all of it. Okay? Like, how is it formed? Does it just happen to happen? No. Okay? Remember what artery did we have at L1? Yes, the superior mesenteric, exactly. So arteries follow veins. So the superior mesenteric vein is also at L1. Okay? You have over here that behind the pancreas at L2, you have the superior mesenteric vein joining with the splenic vein to give me this portal vein. Okay? And again, why are we doing all of this? For nutrient processing, and then the blood is going to go to the systemic circulation. So let me show you it more. Again, here it is. So the blood is going from the intestinal capillaries and is going through the portal vein. Now, the portal vein does not have valves, so it's bidirectional. You can find here oxygenated and deoxygenated blood. And then it's going to go to the hepatic sinusoids, which are found in the liver. What is the point of the hepatic sinusoid? What do? They allow for the exchange between, the blood and the hepatocytes, right? This is where, the exchange happens. And then you're going to have that it becomes a hepatic vein, which drains finally into the IVC. Does that make sense? The inferior vena cava. Okay? So here you can see that it's purple in color because it has both oxygenated and deoxygenated. Okay, easy so far, right? So this is visual for the visual learners. Let's take a closer look at it. Again, here you have the superior mesenteric vein joining with the splenic vein at the level of L2 to give me the portal vein. Okay? And as you guys can see here, the gastric veins are draining into it. The pancreaticoduodenal are draining into it. If I go a bit more up, I can see the cystic veins are also draining into this, right? So these are known as, do you know what the tributaries are known as? صراحة I don't remember them coming in any of the exams, but these are known as the normal tributaries, while the splenic vein and the superior mesenteric vein are known as the formative tributaries. Why? Because they form the portal vein. Easy? This is the word form of everything I've been mentioned. Is all good so far? Are you guys okay? I mean, it's a good concept. It's just that, anatomists always decide to, take things out of proportions. So what do you guys think of this? So good so far? Normal goes directly to the liver without the large portal vein. The large portal vein, you mean like the normal liver supply for, the oxygenated blood? For oxygenated blood, it's both. Again, remember we mentioned it here? We have 30% of the supply is the hepatic artery and the portal vein as well, both of them. The tributaries between the formative and normal. The ones between them, tributaries are kind of like mini branches, So you know how like, let's say, like these, like just these little ones. Like to tribute with something is to like join or like not join, like, give kind of thing. Okay, so it's just small branches that will drain into the portal vein for processing, the nutrient processing. Okay? Okay. Now, do you guys think that the portal vein works together with the caval system? The portal system work, hand in hand with the caval? I personally think yes. Okay? And we have proof of that. We have a whole lot of junctions that show that. The first one being the gastroesophageal junction. What is that? That's the junction between, the gastric part or the stomach and the esophagus. Okay? We have another one, which is the anorectal. So between the anus and the rectum. Then we have the umbilicus, which is found in the anterior abdominal wall, and the retroperitoneal sites. Now, these are not important by name, they're important by clinical kind of thing. Okay. So do you have to know them? Yes, you do. And I'll show you it's easy to correlate them with, the clinical part of it. Okay. So let's say that a person comes in with he's been an alcohol what? He's been a what's the word? Yeah, so he drinks a lot of alcohol. Okay. Wow, you guys are losing me here. Okay. So he comes in with liver cirrhosis. Okay. And liver cirrhosis causes fibrosis to the liver. Okay. So you'll see that the liver looks, yes, alcoholic. That's the word. Thank you. Okay. So you'll see that the liver becomes fibrosed. Okay. And this increases the resistance within the vessels inside. So the pressure inside increases, and you'll see that there's backflow. So now these three are very important symptoms that you see with portal hypertension. What is portal? Again, it's within the liver. Hypertension. So, whoa, I spelled that wrong. Okay, I'll fix that later. Hyper, so there is increased pressure, and then, tension is pressure. Okay, so hyper, too much pressure. Okay, splenomegaly, because of the backflow. The ascites, which is the fluid that are found in the peritoneum, and varicocele. And this is a very important table that you guys have, the same, but less colorful. I tried honestly to come up with a mnemonic for it, but it's just hold on. Yeah, you just have to. What is going on here? Yeah, okay. So for the esophagus, you have the veins or the left gastric, which makes sense because we did mention that the left gastric artery supplies, the lower part of the esophagus. So the left gastric vein is probably involved with the esophagus. Okay, the left gastric vein drains the blood through the hemizygous all the way to the azygous. So these are the veins involved. Now, what would you see if there's a damage? You'll see bleeding and varicocele. And just like you see here, it's like the veins become all shambly and weird looking. Okay. Then the umbilicus, which again is a very very high yield one, especially the caput medusae. I have no idea how to say it ever since last year, but you guys know how Medusa looks like, right? You know how her hair looks like snakes and all that. That's exactly how the veins end up looking. Which veins? There is the hypertension between the paraumbilical and the superficial abdominal. Okay, so abdominal because it's in umbilicus, and paraumbilical. We can try our luck here. Okay, then we have the anorectal, which is between the superior rectal and the middle or inferior rectal. Okay, and what does it result in? Hemorrhoids. Hemorrhoids is also a very clinically significant diagnosis, or whatever it is. So let's zoom in more into it. Okay, hemorrhoids can be either. This is all what I want you to know about it. To be honest, internal hemorrhoids and external hemorrhoids. Internal hemorrhoids come from superior rectal veins. Okay, so they're the varicocele of the superior rectal veins. And again, we said the superior rectal comes from the IMA, so it's found up. It supplies the rectum and the upper anal, so it's inside. Okay, and when it's prolapsed, so when you start seeing it, you see that there's a lot of it in flower shapes or rosette patterns, okay? Mainly at third, seventh, and 11th, which I don't think is honestly important, but just know it for the sake of knowing it. And then we have the external, which are the painful ones, okay? So they are the varicocele of the inferior rectal vein. So the internal is superior and the external is inferior. That's all you need to know, okay? Uh, minute time? What is this? Is like, I would say it's a low yield, but it might come. So what do you guys think of this? Okay. Can you explain why you think it's A? Okay. So we're saying that he's dividing the liver along the functional division. Okay? Yes. Okay. So the falciform ligament is the ligament that divides the liver into a left and a right lobe anatomically. Okay? So if I'm talking about an anatomical division, I'll tell you, yes, you're right, totally right. But when I'm talking about the functional division, I'm thinking of hepatic veins and I'm thinking of the portal veins. Okay? Does this make it clear? Okay. So it's C. Now let's move on to I would say this is a more high yield one. Let's have you guys try it out. Yes. So like I told you, the falciform ligament is kind of like a curtain with a rod on top of it, and this rod is the ligament anterior. Okay, so it's kind of like found within the falciparum ligament. Okay, now I want you guys to solve this one with um explanations to why. Portal hypertension. Exactly. Straight to the point. And what proved that? What made you so sure of saying portal hypertension? Exactly. So splenomegaly is one, and there is more, right? Which ones? Oh, why is it moving? Okay. So you have splenomegaly, you have ascites, and then you have the umbilicus being dilated, and we also have the distal esophagus being dilated. So all of these point to the fact that it's a portal hypertension, and C is that. Great job, guys. Now, last but not least, actually, well, it's still not last but okay, it's literally last but not least. Okay, we talk about the lymphatics. Okay, now the lymphatics, to be honest, are very much ascites, are basically when you have fluids in the peritoneum. Okay, esophagus is from the left. Yes, it's between the left gastric vein and which one? Do you remember? The azygos, right? Okay. So now let's talk about the lymphatics. And I feel like the lymphatics are so underrated. Like we all just fear them. And personally, I fear them as well. Okay. So let's build it from the very down low. Okay. What is the point of lymphatics? Why do I need lymphatic system? I need the lymphatic because yes, fat, exactly. Wow, that's a good one. Okay. So basically, you have the capillaries that carry the blood, right? Now, as the blood is flowing through, it starts, fluids start to leak out, okay? And if this fluid stays outside, you're going to start swelling, okay? Your cells are going to swell. So what happens is that the lymphatic is going to carry this leaked fluid back to the blood. All right. So when I'm telling you about the lymph, I'm expecting you to think of fluid that has protein, it has immune cells, it has fat, right? From there, you can just right away guess what the function of the lymphatic system is. And again, we said it's the cleaning system. It has an immune function and it's for the fat transport system. Okay. Now, it has a way to go through things, and that being tissues all the way to the veins that are nearest to the heart. Okay? So, what happens is that it takes the lymph from the tissues and it sends it all the way to the veins that are closest to the heart. Okay? And it kind of, the way it does so is, kind of similar to a ladder. So, it starts with lymphatic capillaries. What are these? They're basically the tiny collectors of, the fluid within the tissue. Okay? Then we move on to lymphatic vessels, and these are a bit bigger, okay? And they have the valves, right? Then we move on to lymph nodes, and lymph nodes are considered the immune filters of, the whole thing, okay? And last but not least, we have the lymphatic trunks, which are kind of like the highway that would take this lymph to the ducts, okay? I don't know how much that made it easier, but if the stairs didn't work, then take the elevator. Okay, let's read that memo over there. It says clean veins need two drains. Clean, so C stands for capillaries, V vessels, N for nodes, T for trunks, and the D is for ducts. Okay. Now you'll tell me, okay, well, what does that sentence mean? Like, what is the point of it? Well, my friends, let me tell you that the lymphatics have exactly two drains. Okay. What are the two drains? What are the two ducts they drain into? You have the thoracic duct, which is the bigger one. It takes the lymph from a lot of places, like the lower body, the abdomen, the left chest, the left arm, the left head and neck, right? So mostly the left part of the body, along with the lower part of the body. Okay. And then what is it going to do? It's going to enter at, that little angle. Oh, I can annotate here. Wow. Okay, that little angle between the subclavian and the jugular. Over here, you have this little angle on the left side. That's where the thoracic is going to go. And then you have the next drain. Okay, now I can't move the slide. Hold on, guys. Clear drawings. Okay, and then for our next drain, which is the right lymphatic. And this is the smaller one. So it's going to drain mainly the right head and neck, the right chest, the right arm, and it's also going to go through a junction, which is the same junction, but on the right side. So it's the junction between the jugular and the subclavian. Okay? Okay. So let's take this on, a broader way. Let's look at it for the abdominal organs. So this is what we're expecting to see, right? Capillaries, vessels, nodes, and so on. Okay? Let's try applying that. So this is the lymphatic for the abdominal organs. Pre-aortic lymph nodes. Okay, we're starting with big words right away. Let's break this down. You guys see this over here? The lumbar ones, the right and left. The lumbar ones are called the aorta. Okay, so pre-aortic means that it's not just taking from here; it's also taking from the pre stuff. Okay, the pre-aortic lymph nodes, and then it's gonna go into the intestinal trunk. Okay, and then into the cisterna chyli. Now, if you guys don't want to or can't get yourself to remember anything in the lymphatics, I want you to try your best to remember this cisterna chyli because it's a very, very, very huge high yield point. Okay, what is cisterna chyli? It's simply just a reservoir in the abdomen. Okay, at what level? It's at level L1 to L2. Okay, it's a huge reservoir though, which is why it's very, very important. All right, and then it's just gonna continue its way through the thoracic duct, and like we mentioned, it's gonna go through the left venous angle, which is the angle between the left internal jugular and the left subclavian. Okay, let's apply that to the liver. Now, the liver, again, it goes through the liver lymphatics. So you have the hepatic nodes going into the celiac nodes, and then the rest is the same like the other ones. So celiac nodes draining into the intestinal trunk, cisterna chyli, thoracic duct, left venous, nothing abnormal. Okay. Now, what's abnormal though? Do you guys remember my friend over here? The bare area, the guy that is not covered by peritoneum and is directly touching the diaphragm. Remember, we said that he is clinically important, and that's because, infections and tumors from the liver, since, they're touching the diaphragm right away, is going to spread to the chest and the mediastinum without going through the abdominal nodes, right? We mentioned that. You guys remember that? That is a high yield. Okay, so keep that in mind. So that takes us to the way the lymph nodes of the bare area go, which is going from the diaphragmatic lymphatics to the posterior mediastinal lymph nodes, which is the same pathway as the diaphragm. Okay? So this is the only part of the liver that goes through the diaphragmatic lymphatics. Are you guys clear on that? It's a high yield, so if you don't get it, let me know. Okay. Well, to make sure that you did get it, let's try solving this one. So we're saying enlarged posterior, enlargement of the celiac. Exactly. See again. Yes. Okay, so now you guys know the way to answer my questions. If you don't know it, just put C. No, I'm joking. Yeah, I don't know why it's always C, Loki. Like, I don't know if I did that on purpose but yeah. Okay, so yes, you're right. It is C. Okay, so you have enlarged posterior mediastinum lymph nodes, which tells me that there's something wrong with the diaphragm, right? The way the diaphragm passes the lymphatics through the diaphragm, but there is no enlargement of the celiac lymph nodes. Okay. Okay. And now for our actual last part, the gallbladder. Now the gallbladder is possibly my favorite because it's a very small organ, and you think it does nothing, but actually does a lot. Okay, so it's a small organ that is under the liver. Okay, and what does it do? I remember we had our lab doctor ask us that last year, and I remember we couldn't get it, and he got it in the exam. Okay, so you guys focus on this one. So what does it do? It's going to store and concentrate bile. Okay, so never just say store. It stores and concentrates both. Okay, and where does bile come from? It comes from the liver, right? But what even is bile? Bile is just a sticky, yellowish greenish organ, or not organ, sorry, fluid, which is stored and concentrated in the gallbladder. Like, when is it produced? If we're talking about the liver, then I say that bile is produced all the time. But if I'm talking about the gallbladder, then I say that it stores it and produces it only specifically after fatty meals. Okay? So in the gallbladder, it's not produced to the duodenum all the time. It's produced only after fatty meals. Okay? Okay. Now into my favorite part. And since you guys, are first year uni students, I assume you guys are all into driving. So let's see if you can roundabout through these ducts. Okay? So we have our first two ducts, which are the left hepatic and the right hepatic. Now these two join together to give me what? To give me the common hepatic duct. Okay, makes sense. Hepatics giving me hepatics. Okay, good so far. All right. Now, this common hepatic is going to join with the cystic duct. Where does the cystic duct come from? It comes from the gallbladder. Okay? Now, the cystic duct and the common hepatic duct will together give me the common bile duct. Okay? And what does the common bile duct do? The common bile duct is going to is going to join with the pancreatic duct at our big guy, the ampulla of Vater, which has the sphincter of Oddi, and this is the guy that controls the release of the bile into the duodenum or not. Okay? Okay, well let's take things a bit more seriously and let's actually look at it through diagram. Yes, it is the major papilla. Yes, you're right. Exactly. Okay, so this is how the liver looks like, right? The gallbladder, sorry. Okay, so you have here, you have the hepatics that come together, that join together over here to give me the common bile duct. The common bile duct joins with the cystic duct to give me the wait, what? Sorry, guys. The common hepatic duct joins with hepatic joins with the cystic to give me the common bile duct. Okay? Now, this is how the gallbladder looks like, just like you guys can see. Okay? You have over here the fundus, over here you have the body, and over here you have the neck. Okay? Now, the fundus is lying posteriorly on the duodenum, okay? The transverse part. Okay? So it's touching the anterior peritoneal right away. Then you have over here the body. Now, I want you guys to keep in mind that the body normally has little spiral folds that we call by the valve of. You guys know what comes next? Valve of what? No? Okay. So it's known as the valve of Heister. Okay? So what does that do? It prevents the collapse of the cystic duct. Okay? Wait, why am I talking about the body? Okay, yes. Then you have the neck. Now the neck is continuous with the cystic duct, and it normally has two parts. The smooth part over here and the foldy part. Okay? If you guys see abnormal folds, that is known as the Hartmann's pouch. Okay, what is the Hartmann's pouch? It's the pouch that if you see it, you can tell that, okay, there has been, a stone compaction. This person has been affected with kidney stones, okay? Or gallbladder stones, all right? Okay. So this is word form of everything I've mentioned. And now for our clinical significance, which is the very cool part of this all. So you have over here the gallbladder, right? The gallbladder, if you look at it, you'd see that it's at the ninth costal cartilage. Why would I care about this? Why do I need to remember this? Because as physicians, you see a patient coming in with pain, okay? What you're gonna tell them is that you're gonna tell them to take a very deep breath and you're gonna push down. If you push down and it hurts, okay, if they feel pain, then we say that this is Murphy's sign. Murphy's sign is a very high yield, so keep that in mind, okay? And it suggests cholecystitis, okay? So Murphy's sign, remember it. You push down and he feels pain, okay? Okay, now for our arterial supply. Arterial supply is cystic artery coming from the gastric, the right hepatic artery, and the posterior superior pancreaticoduodenal artery. So the pancreaticoduodenal, again, where did we say the superior pancreaticoduodenal comes from? Because these are very important and they get tricky during the exam, under stress. So what do you guys think? Remember we said the big words? Yes, exactly. So the big words come with the big words. Pancreaticoduodenal comes with the the gastroduodenal, okay? Now for the venous, you have small veins pouring into hepatic veins, and some of them will give me the portal vein. So this is, the whole tributary idea. All right? And now for our nerves. To be honest, I don't remember us ever getting a nerves question, but it's important to understand it for, the physiology of it as well. Okay? So you guys know that parasympathetic overtakes the sympathetic when, you have, the whole rest and digesting, right? So when you're resting and digesting, you're quite literally digesting. Why? Because the parasympathetic is activated and it's going to cause the gallbladder to contract. Okay? Now, the minute the gallbladder contracts, the sphincter of Oddi is going to relax and it's going to release the bile into the duodenum. All right? And the other is true. The opposite is true. So what the sympathetic, T7 to T9 in specific, this one inhibits contractions and it's the one that carries the nerves. Okay. Now here the referred pain, it goes the same way as the liver. Okay. So we have again the phrenic nerve C3 to C5 is the one that's irritated, and you're going to feel it as right shoulder pain. So a patient can come in with right shoulder pain and you think, okay, maybe they hit their shoulder, maybe, something happened, but it could be totally different and it could be the phrenic nerve. Okay. Okay. And now for our last part, which is Calit's triangle. Again, very, very high yield. It's a very easy concept, but it's very high yield, okay? Calit's triangle is literally a triangle, okay? Why is it important? Because it has the cystic artery within it, okay? And this is a surgical landmark, all right? طيب, you need to know its borders as well. So you can see over here, the first border is by the liver. The second is through the common hepatic. And then the third is the cystic duct. Okay, so again, liver, common hepatic, cystic duct. And what goes in it? The cystic artery. Okay? All right. So question time. It could come something like this. What do you guys think of this? Hey, exactly. This is a question in the US Assembly book. So if you guys are doing it, that's it. That's one question right. All right, next one. What do you think of this one? A bit long here, but try not to read everything, just skim through the important parts. So we're saying pain in the right upper quadrant. We're saying radiation to the scapula, which is, the backbone. Gallbladder stones. Okay, which nerves? Why T7 and T8? Why didn't we say T9 to L1? Exactly, because it's sympathetic referred pain. Perfect answer. Yes. So sympathetic is the one that carries the pain, and it's from T7 to T9. Why are we not going with this? Because L1 plays no role in that. Okay? And with that, hello? Okay. We end our session. Thank you guys for being here. I hope you guys benefited from this session. And if you have any questions, please don't hesitate to reach out. All right? And please scan the code. Thank you guys.